Welcome back, USMLE Step 2 CK test takers. This is Ahmed Radwan, and we are back with another session. We have the final session for surgery. I think it's number 8. I can't really keep track anymore, but I just know this is the final session. We only have vascular surgery, and then we're going to have some patient safety at the end. So let's get started right away. In vascular surgery, we start at page 347, and it's going to be a question. This is the first thing that they have here. The question says that a 48-year-old laborer complains of coldness and tingling in his left hand, as well as pain in the forearm when he does strenuous work. Recently, he's complained of dizziness with blurred vision and trouble keeping steady during these episodes. Which of the following is the most important management? And now we have 5 things here. The first is going to be aspirin. The second is going to be clopidogrel and warfarin, bypass surgery, and carotid endarterectomy. So what we have here is someone who complains of coldness and tingling in his left hand, as well as pain in the forearm when he does strenuous work. So it has to do with work. And he also complained of dizziness and blurred vision and trouble keeping steady during these episodes. So we have 2 things that happen with strenuous work. He works really hard with his hands, and that is cold and tingling and someone in the left hand only, and the right hand is fine, and he is not able to keep steady. So I'm thinking subclavian steel phenomena. But it is right there, the answer, right after the question. But the answer here has to do with the management. Should we give aspirin, clopidogrel, or what we should do? And I think we should do a bypass surgery here. But we're going to see. I usually block the answer, so I can't really know. But I think it's bypass surgery to bypass the problem here. And the answer, yes, it's going to be D. Bypass surgery is needed for subclavian steel phenomena or subclavian steel syndrome. So what is the subclavian steel syndrome here? It says here that although this condition is rare in practice, you're not going to see it. It's a classic board vignette. So we might see it in a question. An atherosclerotic stenotic plaque at the origin of the subclavian allows enough blood supply to reach the arm for the normal activity, but not enough to meet the increased demands of an exercised arm, like that patient who was working really hard, resulting in blood being stolen from the vertebral artery, which would lead to the dizziness and the unsteadiness episodes. When the arm is raised, there is an increased oxygen demand, of course. The vessels in the arm dilate to increase the perfusion. Makes sense. This dilation acts as a vacuum to blood in the head, neck, and shoulder. And this leads to syncopal, I'm not sure if I'm pronouncing this right, but it's going to be syncope episodes. And the classic symptoms are going to be, first, it's going to be posterior neurological signs, which are visual symptoms and equilibrium problems, so he's not going to be able to see well. Blurred vision is going to be having some dizziness and trouble keeping steady. And the second is going to be claudication in the arm during arm exercises. Okay, so what we should do is that we should not confuse this condition with thoracic outlet syndrome. That's different, which causes vascular symptoms only, and it is not going to be neurological symptoms. So this is how we can compare the two. And the treatment is going to be bypass surgery from the atherosclerotic part. And to know which part we're going to need to do angiography to diagnose that condition. Very easy. I think if we get that question, it's going to be our lucky day. Okay, so the second thing that we need to talk about is the aortic aneurysm. And it starts again with a question. It says that there is a 66-year-old man who has vague, poorly described epigastric and upper back discomfort. He is found in a physical examination to have a pulsatile mass, which is very tender to palpation. An ultrasound reveals a 6-centimeter abdominal aneurysm. What is the next step in management? We have here first to start on ACE inhibitors, an urgent surgery, which I think is not the case. And I don't think we need ACE inhibitors here. Elective repair, maybe. We're going to take a look back. Repeat the abdominal ultrasound in 6 months. And finally, order CT angiogram of the chest. Okay, let's see. It says here that that patient has a 6 centimeter abdominal aneurysm. I think if the abdominal aneurysm is more than 4 centimeter, I think, I'm not really sure, I can't really remember, that we should do surgery. But I'm not sure if it's elective or urgently, but I'm gonna say urgently. I'm gonna say elective repair. I'm not really sure, but let's see. Well, actually, answer is B. It's gonna be urgent surgery. Okay. So urgent surgery is going to be here the answer. It says that within the next day, this is the most appropriate management in a patient with asymptomatic abdominal aortic aneurysm. The signs of hypotension and symptoms like excruciating abdominal pain radiating to the back suggest leaking or rupture aneurysm and necessitate emergency surgery. So it says here on the left side that in an abdominal aortic aneurysm, one-time screening by ultrasonography in men aged 65 to 75 who have ever smoked. So we need anybody who is above 65 to 75, we need to have him screened at least once with ultrasonography if he has ever smoked. Okay. So this was the side note. After the answer here, it says that signs and symptoms are key to management of a abdominal aortic aneurysm. If we have an aneurysm that is less than 5 centimeters, it can be observed with serial annual imaging. So this was not the case in the question. And if it's an aneurysm of more than 5, we should do elective repair. Okay, but here it says. Okay, I'm confused a little bit. So if this is not without symptoms, we do an elective repair if it's more than 5 centimeters. If the aneurysm is less than 5, we observe with serial imaging. But if we have symptoms, I think we should do it right away. I'm not really sure. Well, it says that more urgent surgery is needed in the following cases. Okay, so a tender abdominal aortic aneurysm will rupture within a day or two, and thus requires urgent repair. Also, this was the answer to our question here. Okay, and excruciating back pain in a patient with a large abdominal aneurysm means that the aneurysm is already leaking, and this necessitates emergency surgery. So that's different. Okay, urgent is different from emergency. Urgent is going to be in the next day max, and emergency is right away. Okay, so we have a basic science correlate here that says that the abdominal aorta has 3 layers: the intima, the media, and the adventitia. All right, okay, good. Good to know. All right. So another question here. It says that a 65-year-old man, he presents with severe, sharp chest and back pain down the spine that started 1 hour ago, or started 1 hour ago. His blood pressure is really high, 219 over 115 millimeter mercury. The chest X-ray is shown. I can't really see it well because my book is not really that good, but anyways, we have an X-ray here. An AKG and cardiac enzymes are non-revealing, so we don't have any changes. Which of the following is the most important intervention that would have prevented this presentation? Okay, so we have a severe, sharp chest and back pain down the spine. That started 1 hour ago. His blood pressure is really high. Okay, I'm gonna say that if his blood pressure is really high and he has severe sharp chest pain that started acutely, I'd say he might be having an aneurysm. I'm not really sure. Okay, well, I'm not sure what he's having, but it says here that what we should do to prevent the presentation: an aspirin prophylaxis, blood pressure control, cessation of smoking, low-fat diet, and serious CTs. Well, serious CT is not going to prevent this. And low-fat diet, I don't think so. Smoking cessation is a really good thing. But I don't think that this has anything to do with this. And if it's an aneurysm, it's going to be a blood pressure control. So I'm going to go with it. Okay, so I'm going to say the answer is B. Blood pressure control would have prevented this. Let's see. Okay, so B is the right answer, actually. So that's correct. It's going to be a blood pressure control is the most important strategy to prevent progression of thoracic aortic aneurysms. Okay, so it was an aneurysm. I think the X-ray might have seen anything, but I can't really see it. So yeah, blood pressure control. Okay. The risk factors here that contribute to the development of thoracic aortic aneurysm is going to be chronic hypertension, it's going to be hyperlipidemia, smoking, Marfan syndrome, and untreated tertiary syphilis. The most important modifiable risk factor worsening of existing aneurysm is uncontrolled hypertension. Okay, so uncontrolled hypertension is going to be the most important modifiable risk factor of worsening to the existing aneurysm. First, if we have asymptomatic lesions, blood pressure management is the most important factor in controlling the asymptomatic lesion. If we have a symptomatic lesion, including active dissection, we look for chest pain and sudden onset tearing, pain in the back. These require surgical intervention right away. Okay, so asymptomatic, blood pressure control, symptomatic, do surgery. Okay. Now, another disease here is the arteriosclerotic occlusive disease of the lower extremities. The the classic presentation of this condition is pain in the legs on exercise that is relieved by rest, also known as the intermittent claudication. If the claudication does not interfere significantly with the patient's lifestyle, so no workup is indicated. He's fine. The only management is going to be indicated if is to stop smoking, cessation of smoking, and the use of sulistazole and aspirin. Somebody would ask, what is sulistazole? And I personally would ask that question because I can't really remember. And it says that sulistazole is a selective inhibitor of the phosphodiesterase 3. Okay. So we can use that along with aspirin. If the pain is more severe, however, and the diagnosis is with the following, we do a Doppler study looking for a pressure gradient, so like an ankle brachial index, that's going to be less than 0.9. We can do also an arteriogram to identify the stenotic area, and that would help us with the diagnosis and would actually indicate the severity as well. If the case describes disabling symptoms like affects work or activity or daily living or something like that, if there is impending ischemia to the extremities, then surgery is indicated in this point. We can't really just let that patient go. This is going to be either angioplasty and stenting for the stenotic segments, and more extensive disease, which we cannot really stent or do an angioplasty for. This is going to be requiring bypass grafts or sequential stents. So, again, pain at rest, this would indicate that end-stage disease, and the patient would going to be complaining of scalp pain at night with a disrupted sleep. And again, I think the answer is going to be surgery for the treatment, either angioplasty and stenting, or more extensive disease is going to be bypass grafts or sequential stents. So, that was the arteriosclerotic occlusive disease of the lower extremities. And finally, we have arterial embolization of the extremities. We look for a history of AF or atrial fibrillation. A recent MI was sudden onset, painful, pale, cold, pulseless, parathetic and paralytic lower extremity. Finally, we do a Doppler study to locate the obstruction, and we consider thrombolytics if it is early, or embolectomy if late, and with fasciotomy. And that's it. So really easy, and we're done with the vascular surgery. I'm really happy. We still have one page left. That's going to be page 351 now, and this has to do with the patient safety. Okay, so patient safety. We're going to continue with it. We have two things to talk about. The first is the catheter-associated UTI and central line-associated bloodstream infections. The first one, the catheter-associated UTI or urinary tract infection, is the most common type of healthcare-associated infection and the leading cause of nosocomial bacteremia. So it's really important. The diagnosis is going to be made when a patient has a catheter-related bacteriuria combined with fever, suprapubic tenderness, costovertebral angle tenderness, and evidence of systemic inflammatory response syndrome. The most accurate test here is going to be the urine culture, and I think the first test to do is the urine analysis, but it doesn't really say that here. But the most accurate one is the urine culture. And the treatment is the prompt removal. We need to remove the catheter right away, and administration of antibiotics, of course. How can we prevent this? It's going to be early removal of the catheter, as has been shown to reduce the risk. So as long as we can remove the catheter, we should remove it right away. And how should a patient with long-term indwelling bladder catheterization be managed? So a patient who really has to have a catheter for such a long time, we instruct the patient or the caregiver to use intermittent catheterization, so not have the catheter all the time. And on a side note here, it says that prophylactic antibiotics have no role in the prevention of this or the catheter-associated UTI, and they raise the risk of resistance and Clostridium difficile. So we shouldn't reuse prophylactic antibiotics in that case. Okay, all right. What we should do is to have intermittent catheterization and early removal of the catheter. The second thing is the central light-associated bloodstream infection, and here it says that all catheters can introduce bacteria into the bloodstream and generate significant morbidity and mortality. And if the patient with the central Lyme develops the signs of infection, blood cultures are taken, that's first, from both the catheter itself and another peripheral vein. If the cultures yield similar results, the central line should be removed right away, and antibiotics against the Staph aureus should be started, because this is the empirical treatment here. And we have two questions here. When should antibiotics be started in a patient who has the central line associated bloodstream infection? And it says it should be started immediately after blood cultures are obtained, and we base that upon the choice upon sensitivities. So I would start with something that would combat the Staph aureus, and then if we have a different result upon culture, we can change that. And it says here that should the catheter tip be cultured, and this answer is yes. Central venous catheters should be cultured if the device has been in place for at least 7 to 10 days. So 7 to 10 days, yes, we should culture the central venous catheter here. Okay. On the right side, we have a note that says the Staph aureus, which is coagulase and Staph aureus and the coagulase negative staphylococci and the Candida species are the most commonly isolated organisms in the central line associated bloodstream infections. So we should consider Staph aureus, we should consider coagulase negative staphylococci and the Candida species. Those are the ones that we should look for. Okay, and with that, we are done with surgery. Congratulations if you have been following, and if you're done with it. I'm really happy that I'm done with the surgery. Of course, I can't really remember everything that I studied, but that's fine. We can answer questions later on and try to solidify the information that we had here. And of course, if we follow that with the USMLE world, we're going to be really well when it comes to surgery. I would highly suggest that people would read or see the videos for Kaplan surgery. They are really good. You shouldn't really read the book, but you read the clinical vignettes. They are really awesome. And I think they cover a lot of really good questions that we might encounter. So do that, and I'll see you in the next one. We're not going to continue the 25 minutes here. We're going to start another section, which is pediatrics, right away. And yeah, so keep working hard, keep doing what you're doing, and I'll see you in the next one. All right, bye.